You were involved in a study that looked at the input that a practice-based pharmacist can make to medicines optimization. Can you tell us a bit more about this study? What did it involve, and what were the findings?
I was I get very excited, but I was very excited about this. When I first started working in primary care in 2016, through Wessex Academic Health Science Network, they were looking for sites that were prepared to take part in this study. And it's run out of the University of Belfast, the School of Pharmacy there, Professor James McElnay, who had a PhD student called Nadia Sayafan. And it was incredibly rewarding, but it was a lot of work. But I'm not shy of doing hard work, because I felt that it was really important. So this is when we were beginning to talk about the benefits of clinical pharmacists at the time working in primary care. And even at the top, at the center, they were like, we really need some of these studies to see whether or not using clinical pharmacists to see patients. So in effect, this was like what we now call a structured medication review. So people were recruited, and it was very hard. We had eight practices. We had 6 pharmacists, so 2 of us, me being one of them, we worked in 2 different practices. So we had eight practices, but 6 pharmacists, and it was across the UK. We had some in Northern Ireland, some in the northwest, quite a lot in the northwest, and some in Dorset. I think that was it. There may have been somewhere else. And so people were invited into the study, and so of course it was a rigorously, academic study. So we were trying to get 800 patients to be enrolled, half into intervention, half into control. Now, the hard bit, if you know anything about doing research, is that it was really hard to get those patients. So despite our real best efforts, I think we only got something like 350 patients into the study. But they were recruited if they were either on 6 or more regular medicines, plus they'd had an unplanned admission or 2 emergency department presentations within the last year. That was 64% of the patient population. Or if we couldn't recruit from just those, they had to be on at least 10 medicines. And when I say 6 or 10 medicines, I don't mean a couple of catheters and a couple of eye drops and some gluten-free breads. I mean proper systemic medicines, and we were able to find that information. And then they were recruited half and half into intervention or control, and it was a 6-month follow-up. So they looked at medicines-related problems. In other words, you could make a list of, when you saw the patient, what were the medication problems that you thought that existed. There's something called a medication appropriateness index, which is an academic way of discovering whether or not somebody who's elderly, and whether or not they're on an increased number of drugs that would make them fall, for example, that would be considered to be inappropriate, in inverted commas. And patients were also asked about their beliefs, so as in their beliefs about medicines, but also their belief about quality of life, etc. So if you were in the intervention group, you saw somebody like me as for like a structured medication review at month 0, then you saw me at month 2, and then at month 4, and then it was all wrapped up by month 6. And what essentially it showed was that we reduced the number of medicines related problems. And a lot of that was to do with adherence or adverse drug reactions, or people being on inappropriate medicines that were no longer necessary. We also were able to reduce the academic medicines appropriateness index, but also, quite interestingly, we were able to show, and all of these were statistically significant, we were able to show that it reduced the number of telephone consultations that were made to the practice if you were in the intervention group. Because remember, in general practice, and we should say that, general practice, like all parts of the health sector, is under massive strain at the minute because of COVID. This was pre-COVID. But even so, what you don't want is an intervention or somebody doing a role where it just creates more work. Nobody wants that. So it was really important, and it was helpful to see that actually reduced the number of telephone consultations about medicines. Now, what it didn't show, and I personally think that we'll never reach this holy grail because there are too many confounders. So if you're looking at older patients with multimorbidity and polypharmacy, and you're trying to show whether or not doing structured medication review reduces the risk of death or reduces the chance of them going into hospital, I think there are so many confounders in those patients that it's really hard. And so that's why polypharmacy as, or deprescribing, or whatever you want to call it, doesn't have very good evidence about overall. But I think what this study adds to is, and this is my personal view here, is that if you can increase the quality of life for patients and you can reduce the number of contacts with health professionals, then that is a good outcome, because I'm not sure whether or not you're ever going to be able to prove that that will, increase your life or reduce the risk of you going into hospital. So it's the holy grail, and there are lots of big studies now about to start doing proper cluster randomized control trials about this. And so we'll have to see, but it was a fantastic experience and I loved it. And of course, I still see some of these patients who took part. We called it the Belfast study, and they'd say to me, "Oh yes, you remember I first met you 5 years ago doing the Belfast study." So yeah, it was lovely, and it was good to see that it was finally published.
So a lot of useful information there that people could use to plan services.